Okay, so we're going to explore the concept of minimal intervention dentistry. Before we start to look at the concepts of minimal intervention dentistry, it's important to revisit three important questions. The first, what is dental caries? This is important because our understanding of dental caries determines what our management will be of it. We have spoken about the concept of caries as being a continuum of disease, from subclinical changes in the tooth structures that we cannot see, right through to the ultimate end of the spectrum, which is the cavitation. The public, however, understand dental caries potentially in a different way. That is the cavity. So it's important, if we are to adopt a more minimal intervention approach to the management of dental caries, that not only do we understand the caries continuum properly, but that we assist our patients and the public to understand that it is a disease continuum, and at any point up to the point of cavitation we can intervene potentially to reverse or at least arrest the disease process. So that's a very important question to ask ourselves. The second question is, what causes dental caries? Now, this is important as well, because if we think about how do we manage or prevent dental caries, then it is a necessary starting point that we understand what the cause of the condition is. I have outlined in the caries lectures that dental caries is a multifactorial disease. There are multiple influences or contributors to the disease. There are also multiple protective factors, and we need to understand the relative contribution of each of those factors. Dental caries is an infectious disease, but it is one that is mediated or influenced by a person's social position. So we see in parts of our communities which have a lower socioeconomic position that the disease appears to be more prevalent. So there are greater numbers of caries the further down the social spectrum we move. Conversely, we find that in the best off parts of our community, the disease is relatively minor when compared to the total population. So although we need a very careful biological understanding of the disease process, and we need to understand the chemical process that's involved, the biochemical process that's involved, we also need to be thinking about the social influences on dental caries. So all of those things will potentially determine how we manage the disease. And then that brings us to our final question, is if we understand dental caries as a disease continuum from subclinical curable lesions right through to cavitation, and we also understand that the disease is caused by multiple factors such as diet, saliva quality, the type of bacteria that people have in the mouth, the way they control the plaque, their access to resources and their exposure to protective factors such as fluoride. If we understand all those things, then the picture that we see around us in terms of how dental professionals manage caries doesn't really make sense. Why are we treating a disease which is curable and reversible with surgery? And I think the paper that we looked at reinforces the idea that we are potentially, our clinical management is not keeping pace with our knowledge about the disease and what causes the disease. And our understanding now, which G.V. Black did not have, our understanding that cavitation is not an inevitable outcome of the disease process. If we understand those things, then looking at what it is we're doing each day in the dental surgery, there seems to be a little bit of a mismatch. So these challenging questions need to be addressed before we can start to understand and accept, and for you to support and embrace the principles of minimal intervention dentistry. These are the overall learning outcomes, or intended learning outcomes, ILOs. There will be other mini ILOs which I will introduce in other parts of this presentation to help to focus your attention when we look at particular aspects. But these are the general learning outcomes. So firstly, you should be able to define minimal intervention dentistry. So to describe sensibly and in a concise way what minimal intervention dentistry is. So make sure that you can, in your own words, explain to somebody what the concepts of minimal intervention dentistry are. And that includes a clear understanding of what minimal intervention dentistry is not. The second intended learning outcome is to be able to describe the limitations of the past approaches to clinical management of dental caries. So looking back in time to see how in the past the clinical management of dental caries has been different from the way that it should be today. So I think understanding how things were done previously helps us to understand where we are today, and also you will be provoked to question some of the things that we're doing today as things that potentially were useful in the past, but due to changes in our knowledge or understanding of the disease, and also the technology that's available to us today, means that those things are no longer the best approaches. So being able to describe the limitations of the way we have gone about solving the problems in the past will help you to defend what it is you are doing today. And lastly, you need to be able to outline and also defend or support the principles of minimal intervention dentistry. And there are some very clear principles which are outlined in one of the slides that you not only need to be able to rattle off from memory, but you also need to be able to defend them, because one of the behaviours of a professional is being able to justify your clinical judgment and the choices that you make in terms of the care you provide. So it's important, the important words here are to outline but also to defend the principles of minimal intervention dentistry. In this video, we're going to look at the first two of these intended learning outcomes. So by the end of this video, and in conjunction with the readings and the discussions that we have in class, you should be able to define what is meant by minimal intervention dentistry, and you should be able to describe the limitations of past approaches to the clinical management of dental caries. So let's look at the definition of minimal intervention. What is minimal intervention dentistry? As I said before, it's often a good way to determine what something is by looking at what it is not. And minimal intervention dentistry does not refer to producing tiny microscopic dental restorations or cavity preparations which are microscopic. Although the preservation of tooth tissue and the careful restoration of teeth to make the cavities as limited in their outline as possible is actually part of minimal intervention dentistry. When you talk to, even to some of our own colleagues and use the term minimal intervention dentistry, many people believe that minimal intervention dentistry means doing nothing to intervene. One of the important things to understand about minimal intervention dentistry is that the surgical intervention is as minimal as we can possibly make it. but the prevention of disease, the interventions that we use to prevent, or the therapeutic or behavioural strategies that we might use to help to prevent disease might be maximal. So my approach is that our surgical interventions are minimal, or as minimal as we possibly can make them, but our preventive interventions need to be maximal. So minimal intervention dentistry is not about neglecting people or ignoring the development of disease by doing nothing. It is about using evidence and a curative approach to disease management and control before we pick up the handpiece. So there needs to be sufficient attention given to prevention and management of health, and less emphasis potentially on surgical interventions, unless of course they are necessary. So minimal intervention dentistry is a philosophy. It is a school of thought about how we can best provide professional dental care to people in a way that preserves or promotes their health. And that philosophy is quite different from the very surgical approach that our profession has taken in the past, which is about cutting things out and rebuilding people's mouths. The best tissues or the best oral structures to have in place are those naturally formed by our own bodies. Prosthetic replacements are never as good as the tissues that they replace. So there are two major sort of focuses for, is that the correct, that's not, there's focuses, should be foci is the plural. There are two major foci in minimal intervention dentistry, and we will break these down into smaller parts later on. The first is a focus on curing disease, and this is a relatively new concept in people's thinking about dental caries. We know from the scientific evidence that it is possible to arrest and reverse, i.e. cure, dental disease, dental caries. Sometimes what we achieve is a arrest of disease. So the disease remains present, but it is not progressing. And that sometimes for some people is the best outcome that we can actually achieve. Whereas for other people, and I will talk to you about a study that I've published recently where we've observed changes in dental caries lesions in children's mouths over time, we actually see these lesions reversing or curing. So lesions that are presenting as early incipient or white spot lesions have actually later on in the child's life disappeared from the tooth surface. So there is evidence that we can actually reverse or cure the disease process even after it's initiated. And the second thing that's important is minimally invasive restorative care. So when we do decide to pick up the handpiece and restore damage to teeth, that we do it in a way that preserves, is maximally preservative of the tooth structures. So we only remove those parts of the tooth structure that absolutely need to be removed. And we design our cavities according to the pathology that is affecting them. It also relies on very good adhesive restorative materials which allow us to keep in place much more tooth structure than we were able to in the past. So let's just briefly have a look now at the past approaches to caries management. It's important to look at these past approaches, not because they offer us good solutions today, but they help us to understand why it is we still have some residual or hangover ways of thinking from the past. If you think about your parents, or even your grandparents, if you're lucky enough to have grandparents, they had different ways of doing things, and the ways of doing things that they found useful in the past, perhaps they still employ now. And you might find those people being critical of the way you do things as a younger person in a more contemporary environment, they may be critical of the new ways that you do things. This is the same with the dental profession. It is very conservative, and it is very difficult for a dentist who's been practicing for 50 years to actually admit to themselves and to their colleagues that what they were taught at university perhaps needs some modification now, given the advances that have occurred in practice. The problem is for the profession, I don't see it as a problem, but if someone has to turn around and say, well, actually what I've been doing for the last 30 years, we now know is potentially not the solution to those problems. That can be difficult for some people because it challenges their own concepts of themselves and what they've done in the past. We need to be understanding of that, and we need to accept that, even me, a relatively young, gorgeous person, did things in the past in dentistry which I now look back and think, oh, if only we had known what we know now, I would never have selected that type of treatment for my patients. But we can only know what it is we know. So we need to be relatively forgiving of those people, but also we need to be accepting and help them to accept also that things have changed and moved on. And the reason I'm talking about that now is because you may find some resistance to what are seen, like your grandparents, as newfangled ideas that challenge their own beliefs and understanding about the world and the way things should be done. So the original approaches to caries management were quite aggressive, and the reason they were aggressive was because, one, there was no understanding that we could actually reverse disease. So people presented basically at the end point with large cavities in their teeth that, unless they were treated with restoration, would actually lead to pain and then tooth loss. The other limitations of the past were that the materials we had to work with, largely dental amalgam, which is an alloy, a metal alloy based restorative material, had no adhesive qualities and required quite stringent geometrical cavity preparation in order to mechanically retain the material. This combined with the fact that amalgams that were produced 100 years ago, they were pretty low quality. They had built-in faults, corrosion, creep, all sorts of things that modern amalgam doesn't have. All of these things meant that the cavities that had to be prepared were actually quite large and sacrificed much healthy tooth structure in order to create a box or a cavity which could accommodate the restorative materials. Here is an illustration of the past GV black cavity design. In the top left-hand side of the screen, you can see a radiograph, a bite wing radiograph, and if you look at the tooth at the top of the mouth at the back, so this would be a 2-6. If you look at the 2-6 there, you can see that on its mesial surface there is an indication, a dark area, that suggests that the tooth has a small cavity. Now, if you look at the size of that cavity on the radiograph and then compare it to the picture in the lower right-hand side of the screen, that is the GV black determined cavity preparation that is necessary to retain the dental amalgam. So you can see that what's been cut away is a lot of sound tooth tissue as well as the diseased tissue itself. We also see that on the occlusal surface, a sound part of the tooth has been cut away in order to provide a mechanical lock for the amalgam. So this type of approach for very small lesions like this was quite destructive of sound tooth tissue. This is the type of cavity preparation that we are trying to move away from. When we do have to actually pick up the handpiece, we should be approaching it in a much more minimal or preservative way. This is a case study that we're going to revisit throughout this presentation. What I would like to draw your attention to here is the lesion on the mesial surface of the forceps. So the forceps is the tooth that is in the left-hand side of the screen. In the lower arch is the second tooth from the back, and you will recognize that from your dental anatomy knowledge. There is a small and at the moment non-cavitated lesion on the mesial surface of the forceps. I want you to remember this case study, and we will come back to it again in later slides. Now, the general challenge that I pose to you is, if we believe that dental caries is an infection that can be treated therapeutically or medically with control of the bacteria, then why are we utilizing a surgical or amputation style approach to its management? And we will have multiple discussions in the class about this particular concept. But this is actually the past approach to the management of dental caries, is either waiting until the finger becomes gangrenous and then we are forced to amputate it, or dealing with the early disease with a surgical intervention. So as soon as we see changes in the tooth structure, whether it is cavitated or advanced or not, we would intervene with a restoration. This is the idea that I believe, and those who are proponents of the minimal intervention or preservative dental approach put to you. This is the challenge. How do we move organized dentistry from the past approach to one where we're treating the disease in a therapeutic or medical approach? And part of understanding why it is that the surgical approach is still so powerful in clinical dentistry is to look at the way we teach dental students and oral health students. Much of the focus in our schools is on the acquisition of surgical skills and restoration skills. So cutting disease out and rebuilding people's mouths occupies a great deal of the curriculum in dental schools. Because of this, there is an erroneous belief that is established in dental students that that is what dentistry is necessarily about. Now, the reason there is such a focus within the curriculum on these things is because these are skills that take a long time to perfect. It does not mean that these are the skills that are the most important in terms of patient care and the maintenance of health. There's also a belief amongst our patients, and our patients put pressure on us to act in particular ways. There is a belief in our patients that a restored tooth is equal to a healthy tooth. And we will explore why this belief is misguided in slides coming up. But where does this belief come from? Are we guilty as a profession of maybe not explicitly telling our patients this, but we potentially allow them to believe this because it's actually easier to do that than to try to explain to patients and then justify the idea that our treatment is only short-term in terms of solution for them. One very important thing to understand about restoration of teeth is that once we make the decision to surgically intervene by cutting a tooth and placing a restoration, what we are doing at that point is entering the patient into what's called the cycle of restoration. The cycle of restoration was described by Alderton many decades ago. And basically the idea is that once we enter them into a cycle, once we enter them into having a filling, They are then caught in a cycle where they will need to, over time, as long as they live, have that tooth re-restored as the tooth material fails. Each time a new restoration is placed, we inevitably make the cavity larger. The larger the cavity, the weaker the tooth. The larger the cavity, the larger the restoration. And the larger the restoration, the more likely that it is going to fail earlier. We don't have a restorative material that does not fail. And yet this is one of the things that we do not share with our patients. Again, the reasons may be that for us it is actually much easier just to allow patients to think that the restorative material will last forever than it is to try to get them to understand that the solutions we're offering them are only short term. So once we make that decision together with the patient to restore their tooth, that tooth has entered into a cycle of re-restoration. And this is the analogy that's used to help us understand how this cycle works. Patients attend the dentist. The diagnosis of the disease is uncertain. And that's because there are some cases where we are unsure about whether a carious lesion is progressing or not. Sometimes we're even unsure whether there has been a cavitation or not, particularly when we look into the deep fissures of a tooth or between the teeth where they touch each other. It is difficult to visualize to determine whether we have a cavitation. Dentists and oral health therapists have an urge to place restorations. That's what they want to do. And one of the reasons they want to do it is because it's actually rewarding for them to do it financially, and also professionally. It is a powerful thing to be able to do, to perform surgery on someone. So there are these intrinsic rewards that make us want to do these things. This unfortunately leads to idiosyncratic restorative decisions. So we will make decisions based on features of the person or the situation that we find ourselves in that are really not related to the biological mechanisms that we know are at play. We do some things for some people but not for others. And this idiosyncratic way of making decisions, which is not always well informed by evidence, means that we make the wrong decisions sometimes. The other thing is that restorative dentistry is technically and physically demanding, so we need to be able to do it very well for it to be successful. Unfortunately, we are tired. Patients do not behave in the way we would like them to sometimes. Patients make choices about materials that we may not agree with based on cost and other factors. How a restoration looks, for example. People will commonly demand that they have the white, so-called white fillings, when we know that in some circumstances the metal-based fillings or even a gold crown is going to be more durable. Patients will demand things. All of these things mean that we place sometimes mediocre restorations that, as I say, have limited lifestyle, so built-in obsolescence. We're also not very good at determining how frequently we should see people. We have approaches to recall in dentistry where we just say to everyone, come back in 6 months, regardless of their risk, regardless of their habits or behaviours or lifestyles. We treat them all the same, so there's uncertain recall. There's uncertain periods of time in which we might want to check that a restoration is performing well or not. Unfortunately, the restorations will fail, but here's a very interesting thing. Commonly when we see a failed restoration, one that either we've placed, or more likely if it's been someone else that's put the filling in and it's failed, we often fail to ask ourselves the question, why has the restoration failed? We move very quickly from observing a failed restoration to restoring it without thinking, why did the restoration fail? And sometimes the restoration that we replace with a new restoration fails for the very same reasons that the initial failure occurred. So before restorations are replaced, if they have failed or you consider they have failed, you need to be able to determine why that original restoration has failed. And commonly it's failed because we have not dealt with the disease. We have not addressed the disease process. We have merely placed a restoration. We have an urge to replace restorations. Restorations are replaced. Each time we do that, as I say, we perpetuate the errors because we do not ask why the original thing has failed. And the tooth get weaker over time, the cavities increase in size, and the restorations become more and more complex and more expensive. So people become dissatisfied, and the whole cycle continues onwards. So it's not a good place to be caught. So what we need to do is to think, looking at this picture, where can we actually make a difference? Where can we actually intervene in this cycle to prevent patients or particular teeth within patients' mouths from being entered into the cycle of restoration? I think it's in the area of diagnosis. So being more sure about diagnoses, or if we are unsure about diagnoses, before we cut off the finger, we actually pause and give the patient or the tooth an opportunity to demonstrate that our decision making has been correct or not. So is the lesion progressing? We can only tell if we see the patient more than once. If we see a patient once and decide at that very first visit that a lesion is active and needs intervention, that is dangerous, because the lesion may or may not progress. Unless we give it time and reassess at a second time point, we have no idea whether the lesion would have progressed or not progressed. And yet, many patients see a dentist for the first time, and at that first visit, treatment decisions are made. I'll come back to the case study to talk about this concept later on. Here is the clinical case which we looked at in the classroom, or we will look at in the classroom depending on when you're viewing this video. This is a patient who was receiving regular dental care in an undergraduate dental clinic. So had very good, what we would call regular dental care once a year. They were coming in for an examination, a treatment planning, and then they received dental care. Cost was not an issue because this was an undergraduate dental clinic. There were no fees charged, and expertise in materials and equipment were also not a limitation, because all of those were available in this university setting. But you can see the patient's presentation is not one that we would consider to be terribly attractive, or from a dental health point of view, not one that we would consider to be terribly successful in the maintenance of this person's oral health. The reason this person looks like this today, the reason this person has been subjected to re-restoration of all of these teeth, was that the underlying disease was not addressed. This patient was feeding the bacteria in their mouth with Manuka honey as a therapy for gum inflammation. However, this patient managed to move through many years of regular and what we probably would observe would be intensive restorative dental care without anybody once asking the patient about their dietary habits or their other lifestyle issues, which subsequently turned out to be the reason this person was suffering from dental caries at each visit. We can see in this picture multiple restorations which are failing. We can see multiple restorations, particularly along the cervical margin of each of these teeth, where the restorations themselves are surrounded by recurrent or new decay. So I think this is an example of how restorative dentistry, or filling teeth, is not a solution, or at least is not in and of itself an effective approach to managing dental disease, namely caries. Here is another patient from an undergraduate dental clinic, and you can see they are a regular dental attender because they have multiple restorations, re-restoration of restorations. You can see a multitude of different types of restoration, but again, particularly around the cervical margins of these teeth, dental caries is undermining the restorations which were placed in this patient's teeth. This patient also has multiple missing teeth, and the teeth are missing through a combination of periodontal disease, but many of them are missing due to dental caries which has been unmanaged and advanced to a point where the tooth has been lost. And the interesting thing about this patient is that a denture, a partial denture, has also been constructed to replace the teeth that you can see that are missing. This denture itself has acted to further undermine the patient's tooth health by holding dental plaque in place against the teeth and preventing cleansing of surfaces of the teeth. So again, not what we would call a huge success in terms of restorative dentistry as a solution for dental caries. This is an extreme case, of course, but the point I'm trying to make here is that if we focus purely on restoration of teeth or filling cavities as our sole approach to managing dental decay or dental caries, we're not going to get terribly far. So let's look at now our modern understanding of dental caries. We know, and we have strong evidence to support these beliefs, that dental caries is an infectious disease. The bacteria that are implicated with this disease are transmitted from person to person. I want to caution you, though, when I say that, to understand that you, as an adult, are probably not likely to catch dental caries from another person. But the bacteria that are associated with dental caries are not found in the human mouth at birth, but they are acquired as a child develops and grows. And there are some important periods potentially when acquisition of particular types of bacteria will determine that a person will go on to develop caries or not. But what we need in place in order for the disease to manifest is a susceptible host. So we need a person with teeth on which plaque can lodge and be protected from disruption. So anywhere on a tooth in a mouth where plaque is allowed to stagnate undisturbed, it can then lead to disease progression. We also need, for example, if you have no teeth, for example, you cannot get dental caries, but that's an extreme solution to preventing dental caries, and probably one that most people would not find acceptable. The other thing you need is the cariogenic bacterial flora. Now, we probably all have types of bacteria in all of our mouths that are associated with dental caries. There are some species or strains of those bacteria that are more virulent than others. So, although we may all have the type of cariogenic bacteria that's necessary, we may not have sufficient numbers or bacteria with sufficient virulence to manifest the disease in our mouths. We also need a diet which contains refined carbohydrates that the bugs are able to metabolize to produce acids which cause dissolution of the tooth structure. Now we need all three of these factors in order for disease to manifest. So if we're thinking about caries management or preventing disease, then a simple response would be to knock out or at least reduce or overcome one of these factors. If we can manage or reduce all of them, then the likelihood of disease progressing is much less. So that should be our focus in terms of preventing disease, but also in terms of curing or treating disease in someone's mouth. These are the areas that as clinicians we should be focusing on and trying to influence. And minimal intervention dentistry philosophy captures these strategies. Remember, dental caries is not simply a hole or cavitation that a lot of our patients and the public think that it is. It is a dynamic and ongoing process with periods of activity, periods of no activity, reversal, progression. It is a dynamic process. And the manifestations of dental caries can present as lesions at any point in the continuum. So they can look like white spots, they can look like cavitations. All of these things are manifestations of the disease. And the important underlying point here is that at any stage, right up to the point of cavitation, if we can achieve the right ecological balance on the tooth surface, we can theoretically reverse or arrest the disease process. These pictures are illustrations of carious lesions. It's important to remember that carious lesions are defined as the clinical manifestation of the disease process at one point in time. So if we remember that dental caries is a disease continuum, at one end we have very early subclinical, so non-visible or subclinical changes in the tooth tissue in response to the activity of the biofilm immediately adjacent the tooth, right through to the collapse of the tooth structure into what we call a cavitation. So remember, there's that continuum. Anywhere along the continuum, we may see a clinical manifestation of the disease at a particular point along that continuum. So we may see, like the top left-hand side picture here, the so-called white spot lesion. So the white spot lesion indicates that there has been mineral loss from a localized area of the enamel, and the white spot appears because of the changes in the refractory index of the enamel within the body of the lesion. So the refractory, the light movement through the tooth is influenced by the loss of minerals. So it appears as a white matte area when compared to the adjacent sound tooth tissue. So the manifestation, the white spot lesion, is a result of that difference in light refraction through the different parts of the tooth. The white spot lesions are non-cavitated, and so at this stage they can be reversed. If you look at the top right hand side of the picture, or the picture of the top right hand side of the slide, you'll see a cross section of that white spot lesion. And the interesting features about these white spot lesions are, you can see the surface layer there, and then the body of the lesion underneath the surface or below the surface. The surface area, that thin sort of strip across the surface of the tooth, is actually highly mineralized. So it has very high levels of mineral. As we go deeper into the body of the lesion, we find a demineralized tooth structure. But at this point, the surface is intact, and if we judiciously introduce fluoride and calcium and phosphate ions to that tooth surface, they can be reincorporated into the lesion, and we can get arrest and even reversal of the lesion. And the bottom pictures indicate the other end of the continuum, that is the cavitation or the breakdown of the tooth surface. And on the left-hand side, you'll see, and I think I've shown you these pictures before, an occlusal surface that has a breakdown. We can see clearly into dentine, and the patient probably, in this case, is not able to keep the plaque or the biofilm controlled within the depth of the lesion. So what we have here is a protected area where the bugs can collect. They can produce acids which are going to continue the disease process. The biofilm cannot be cleaned off the surface of the dentine, and so in this case we would probably intervene with a restoration. And remember, the restoration's job is to bring the biofilm to the surface so that it can then be effectively removed by the patient. If we look across to the right hand side in the lower two photographs, the right hand picture with arrested caries written on it, this is actually a cavitated lesion which again is into dentine. So we're looking at the area along the gum line, right, where we actually have arrest. So what's happened here is the biofilm, because the cavity is relatively shallow, the biofilm is able to be controlled by the patient with a toothbrush, and if they're using a fluoride toothpaste, they're actually remineralizing the surface. So removal of the plaque or disruption of the plaque and the application of the fluoride toothpaste has actually meant that even with cavitation into dentine, the lesion has become arrested. It has stopped progressing. So in this case, if we can be sure that the patient can continue that plaque disruption and applying the fluoride, a restoration is not necessary, unless of course the patient is concerned about the appearance of this lesion. What would concern me more, and I think I said this to you before, is the cavitation which we can see on the buccal surface more towards the occlusal. That is a plaque retentive area that the patient is not able to clean effectively. So this slide is basically showing you those different types of lesions. The stage of the lesion and its activity or inactivity should be what is informing our treatment or therapy decision for those lesions. Now, with the white spot lesion, picking up the handpiece and cutting it out would definitively remove the lesion, but it would not address the disease process, and it would also then enter that tooth into the cycle of restoration. There is a chance with these white spot lesions that if we get the right ecological balance in someone's mouth, apply fluorides and monitor the lesions, that they will actually arrest and we will avoid the need to cut into the tooth, and therefore that tooth will not be entered into the cycle of restoration. So each of these lesions would require a very different management approach by us as dental professionals or dental practitioners. So one approach does not fit all scenarios in terms of disease management, and that's the important thing to remember.